Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. We're broadcasting live with you from the Dolph Simons Family Studio. We're glad you're with us, and I'm happy to be back after a couple of days being outside. You probably know enough about me by now that you know I enjoy that, and we had a great time. We have a couple of special guests. Of course, we always have Doc Hawk. I guess he's still a special guest. I don't know. He's just kind of part of our show now. And then the other person we have with us this morning is Patrick Sallee. Patrick, I've known for a number of years now. Patrick does a great job as the Vibrant Health CEO. Vibrant Health is a federally qualified health center, which means it works with challenged populations due to economics in the community in and around Wyandotte County. It has been a special journey for this group because it's the first FQHC that really was dedicated to Wyandotte County and has really done great work in that county. He has an update for us, and it does sound challenging. Unemployment in Wyandotte in March was around 3%. In May, it went up to 14%, and it's still really high, around 10.3%. So that's a difficult thing, especially if you think about the trickle-down effects of that on the economy and what it means to people who don't have a job and what it means to folks who are struggling, trying to get by when the unemployment rate's so high. And what we know is a lot of people in Wyandotte County are also what we group into that first responders or the first line of employment, people who really couldn't take time off and shelter at home because of the coronavirus. And as a result, because their jobs required them to be at work, a number of them were exposed. And so the rate of coronavirus was really high in Wyandotte County. Then again, there are also multi-generational families, so it's a different, living together, so it's a different environment, and one that we have to be especially cognizant of as we try to take care of each other. So Patrick is here with an update and what we need to know about the things that are going on for Wyandotte and how that's affecting the health of Vibrant. But first, Doc Hawk, how do we look?
We look good today. I think we need to take up a collection and maybe keep you away from the hospital.
Many have thought that. I was always a bad magnet.
All the pennies help.
Yeah.
Because when you were here last, I think we had 35, 36, 37. We have 25 patients inpatient today. So that's very good. 11 of those are in the ICU and 6 of those are on the ventilator. So our numbers are definitely down from where they were last week, which is a very good thing. And I think around the city, especially in the ICUs, from what we heard on our last ICU call, they are down as well. So that's very good, but we still know that the virus is out there and spreading, despite an overall decrease in the amount of testing throughout the U.S.
Yeah, so that's great. Although the 6 people in the ventilator, that's tough. That's a harder journey.
Yep. Yeah.
So Patrick, how are things in Wyandotte? Talk to us a little bit about the challenges that are faced with both Vibrant and the folks who live in Wyandotte County.
Yeah. Well, thanks for having me. I appreciate the opportunity to share and appreciate the partnership and support from the health system. So things at Vibrant Health are going fairly well, all things considered. We keep seeing more patients in clinic and getting people back into regular primary care. We do outpatient medical, dental, and behavioral health care. We see about 10,000 patients a year. And so we've done a lot of work in the last 6 to 8 weeks in getting more patients into their regular care. So one of the things that we've seen is people have delayed coming to the doctor for diabetes checkups or other chronic disease management appointments because of concerns around COVID-19. So we've been able to increase visits and get more people back into regular care, open up our dental practice a little bit more, which has been good. We've also been doing testing, COVID-19 testing in the community in partnership with the Unified Government Public Health Department and a group they formed called the Health Equity Task Force. And that group helps us coordinate and plan where we're going to be, but we're at locations Monday through Thursday. Swope Health Services is a partner in that on once a week. And we've tested in the last 2 or 3 months, we've tested about 2,500 people through just over 40 community test sites. So the testing has gone up and down in terms of numbers of people. So last week we were testing 100 to 125 people per day. This week we've seen a little bit of a drop, more like 30 or 40 per day. But the percentage of positive tests continues to stay pretty high. I think last week it was around 29-30%. So this has had a big impact on families in Wyandotte County. I'm optimistic that people are taking advantage of testing opportunities, which is critical.
Yeah, and that is a big percentage, Dana, because our percentage here at the health system, what is that now? What do we run our positive percentage rate in?
I thought it has been running for the most part 7 to 9%, I believe.
Yeah, and so you guys, obviously a different testing population and people who are coming to seek you out to get tested, but 30% is a high.
Yeah.
That's really high. So just to reflects again on the special challenges. And I think Vibrant's to be congratulated for going out and going to folks in their community as opposed to, and we saw that photo there briefly, but as opposed to having people have to come to you, you end up going to the community. Talk to us a little bit about the genesis of that.
So part of it was right as this got going in, I guess in March and April, some pop-up testing started in Wyandotte County, and the Unified Government was doing testing at their main location, but it's a centralized location, same place every day. And what we heard from community members in this Health Equity Task Force is that we need to be out, the collective, we need to be out into the community in multiple spots with a bigger presence, and we felt like that was a role we could play. We weren't doing testing at the time in our clinic. This was back when test supplies were still pretty minimal, and so we felt like we could play this role in going and standing up testing every day at a different spot. And we've partnered with churches and other nonprofit organizations that can help promote to their clients or their population, their congregation to come, and so that's been really good. And the vast majority of the people we've tested are from Wyandotte County, but frankly we see people from Jackson and Johnson come because there's just limited testing, community testing around the metro.
Well, and we want to thank Vibrant because I think one of the great things about Vibrant is it just does good. And we need more doing of good.
Yeah.
Mm-hmm. So Jill, let's check and see if there are questions from media this morning. Not hearing any? We're going to switch and see what questions are coming from our listening audience because we know there are a lot.
So yesterday, we're going to start with a question we had yesterday from Melissa, and she wanted to know about RLF 100.
Oh, boy, here we
and
go.
Yeah.
Dr. Hawkinson was going to
Yeah, we have
Study
some
up on that.
follow-up.
Vasoactive intestinal polypeptide.
Yes.
Talk to us.
So we do have a trial going on, not with that one, but Dr. Leslie Spikes is heading that trial here at the health system for a similar type of compound. So we are enrolling people in that type of trial. Again, not specifically that compound, but a similar one from a different company. So
Talk to us a little bit how that works, because vasoactive intestinal polypeptide is something we all make.
Right.
But RLF is a drug to try and mimic VIP.
Right.
Well, that's what vasoactive intestinal polypeptide is. So,
VIP.
A, what does it do normally, or what do those whole classic compounds do? And B, why are we mimicking it?
Yeah, basically we're just trying to reduce the inflammatory process. Typically we give those types of things for gastrointestinal type diseases, but now we are trying to give those in order to, it's just one more product that we have looked and seen maybe we can repurpose this drug for an overall reduction of the inflammatory process in the body, basically.
So VIP is an important thing that your body makes, chemical that your body makes to help with the digestive process.
Yes.
So there are drugs out there that try to, if you don't make enough, they can make it for you. And we are now repurposing those drugs to try and see if they have effect of SARS. You think, well, why would you think something for the gut does that? Well, it turns out that it works by helping to decrease the effect of SARS-CoV-2 on that receptor in the airway. And just why that is, that's one of the mysteries of the body.
Right.
I don't know why VIP also affects the airway like that, but it does.
Yeah.
And so in this case, if we give it, it may help clear the virus more rapidly from our respiratory system.
Yes.
And so that's the theory around RLF. And I think there were some early reports that it markedly improved people who are on ventilators in a very rapid fashion by helping clear the virus. Now, whether or not those simple reports, not simple, that's not fair, but the early reports of a few cases really means there's a great future for that drug. I don't know. That's what the study's for.
Right, and that's that's the interesting thing is a lot of these drugs that are being studied have so many different mechanisms and so many different sites of action that we are really, and I think it's good that we are continuing to explore them so that we can really try to reduce the progression to severe and critical illness and death with using some of these. And again, as we move forward, it may not be using them in everybody. It may be using them at certain time points in the infection, whether it's early or late. And those are the things that we need to find out, too.
And that's a study we're trying to do.
Yeah.
Yeah. So talk to us a little bit about Dr. Spike's study. Is it similar to VIP?
It is. So it's a similar compound. It's a different company.
Different company.
But we are also, she is on the floors every day looking at consenting people to do that. So it's not just critical illness, but it's anybody, if they meet criteria, to enroll in these studies.
Yeah, so, it's fascinating. All the things that are happening as we go at Operation Warp Speed, and again, I try to return to Star Trek, but it's also just about having the whole community really focused on developing new ways of thinking to go after the novel coronavirus.
Brandon has kind of a follow-up question to your discussion. Any update on the antibody therapeutics that are in trial? If effective, would that mean we could effectively get back to some normalcy before potential vaccines?
Oh, here we go. This is another hot topic because the role of antibodies, and can we get that done before we can get the vaccination going? Because even if you have vaccination, you may still need the antibodies, just to say. And I think there is some encouraging data out there about looking at convalescent antibodies. Can you talk to us a little bit about that?
Convalescent, so again, the plasma with the antibodies for people who have recovered. Again, we have Dr. Elatruni working with the Mayo Clinic here at the health system to enroll people in those studies. And yesterday we had talked about Eli Lilly is doing a phase 3 trial of their monoclonal antibody, meaning one specific antibody that they have been able to produce to help reduce infection. And I believe they are actually rolling out trucks to different sites to be able to encourage people to enroll, to help people who can't get those, such as nursing facilities, giving it maybe as a protective factor, but also as a therapeutic factor. So there are several companies now who are working on monoclonal or single antibodies against coronavirus. That is just one of the companies, and as we move forward, we don't know the role. Hopefully we are looking for the role as far as even protection against infection if you've been exposed, or as well as treatment.
Yeah, it is interesting because what the body does is it uses those antibodies to help prevent the virus from prying into the cell and opening it up and causing the damage that it does. And we know that our body makes those antibodies, but it makes them after you've been infected.
Yeah.
So if you can get those antibodies very early in a high enough titer, and what we know is we can go about and make those antibodies now. I mean, this is kind of really novel stuff because 10 years ago we couldn't have done this.
Yeah.
But now we make them all the time.
Yeah,
and
absolutely.
it's fascinating how fast medicine has come in that regard. And those antibodies are now used in many different kinds of treatment: cancer therapy, infectious disease therapy, also used in rheumatologic diseases like lupus and rheumatoid arthritis. So lots of different things, asthma. So we've used them extensively. This is not a new idea now. It feels new to us because we grew up in medicine. But the antibodies may have a really important role, and at least the preliminary data around the convalescent studies for the COVID-19 is encouraging.
Yeah.
And so that's something we'll try and have a further update in the near future about. Maybe we can get Dr. Elatruni down to help talk a little bit about that.
He's been working really hard.
He's our primary investigator for our trial at this site.
We've given, I think, at least 60 to 70 unique patients the plasma. So that is the convalescent plasma. That's just a collection of a lot of antibodies from somebody who's been infected and recovered, but then it's the monoclonal, the single antibodies as well. And again, just as you said, it's not new technology. We've been using it for decades for different things like cancer and other infections. But
yeah. All right, Jill.
So Caitlin with 41 Action News, they've been noodling around in the newsroom a discussion about lack of insurance and the different demographics. And I think what she said, one of the things they wondered is that an incentive to people to stay well? But they also recognize that people are sick of other things, not just COVID. So she's wondering, is the lack of insurance impacting the people that you serve?
Absolutely. So we serve, I said, 10,000 patients annually. About 45% of them don't have, 45% of the people we see don't have insurance at all. I think one of the things we're seeing an increase of is when unemployment rate goes up, as Dr. Stites mentioned before, insurance in many ways is tied to employment. So we see an increase in the uninsured population, and in Wyandotte County that's higher. So people are limited on places they can access care, and we're one of those places, so we operate on a sliding fee. So it's based on income, and generally about $25 is the bottom of our sliding fee, and that's what most people pay. But the lack of insurance is preventing people from accessing testing and care. So there's fear because they don't have insurance of what the result's going to be. And so we are interacting with a lot of people who don't want to be tested because they don't want to have to deal with the results after that, and which is a big problem, because then that means they are potentially carrying the virus around without knowledge, which is a problem. But we also want to make sure people stay healthy. So the lack of insurance is definitely inhibiting people's ability or people's willingness and ability to access care.
And to follow up with that, Patrick, what we know is that patients who are coming from Wyandotte County tend to come in sicker. Mm-hmm. And we know that people in general are coming in sicker into the hospital, whether even if it's from Wyandotte or elsewhere, in part because we think there are a couple of things. First, folks don't have a lot of time off to go to get care because they had to take that time off during the shelter in place, and so they don't want to come to the hospital. They don't want to come to see their doctor, so we know that that's been harder for folks. And second of all, when you don't have insurance or you have a high copay with your insurance, even if you are insured, mm-hmm. you tend not to have the money to afford that right mm-hmm. now. Right. And so these are just difficult times, and they affect so many different folks so much. And I think clearly if you don't have insurance, that's bad. But even if you have insurance, the co-pays and just getting time off from work, as you mentioned, a lot of insurance is through your work, may make it difficult for you to go get care. So these are hard times for most folks out there trying to deal with healthcare issues in the midst of a pandemic when, man, healthcare issues are front and center.
And Simone has a follow-up question about demographics. She said that previously we've had Wyandotte County Public Health Department folks mm-hmm. on,
sure.
and they talked about COVID disproportionately affecting, in the beginning, African Americans, and now affecting the mm-hmm. Latino community. She's wondering what you're seeing.
We're seeing the same trend, and part of what we're trying to do and why we're doing the community testing is to get out to communities that are harder to reach and have a harder time accessing care. So we are definitely seeing minority communities hit much harder with COVID-19 than others, and part of that goes back to what Dr. Stites mentioned early about families living together and working essential jobs and not being able to work from home. I mean, the percentage of people that are minority that have to work from home compared to people that are white it's a 15-20% difference. And that drives, I guess, increased likelihood of contracting the virus. Yeah.
Well, I just think being out and around mm-hmm. makes you more vulnerable, right? And especially in first-line work where you're often exposed to lots of different people, and hopefully you do, but maybe not always have all the right PPE. So mm-hmm. I think that's one of our great challenges right now.
And Christy, waiting on the pulmonologist to come back, she has a lot of questions around asthma. Two in particular, does it make her higher at risk for getting COVID? And secondly, does it make it harder if you have asthma to recover from COVID?
You bet. Risk is not really defined in terms of acquiring the disease by the diseases you have. It's by the behaviors of yourself and those around you. So I don't think that having asthma necessarily puts you at a higher risk for getting COVID. What it can do is make it a more difficult course and perhaps even a worse outcome. But a lot of that it depends upon, and we don't know the exact gradation. So is there a relationship between how well you do with COVID and the underlying diseases you have? You bet. Is there a relationship between how severe your asthma is and how you do? We believe that that's also true. Is there a switch or a point on a curve at which you can say, I have really mild asthma, so I'm not at increased risk, or I have really severe asthma, so I am at increased risk? We don't know that. We think that that's true, but we don't really know that as well just now. I was looking at some data this morning on cystic fibrosis. Now, it's not asthma, it's another type of lung disease. What we know is that there have been about 4,500 patients that have been infected so far, but not 1,400 people have been infected so far with CF. There have been 3 deaths, and they've all been people who either had a lung transplant or had more severe disease. So does that mean the same story is true in asthma, that you really have to have more severe asthma in order to have the highest risk of doing poorly with COVID-19? I don't know that that's true. I suspect that that's true, and that's what I would preach to my patients. But I think it's really going to come down to just, as we always say, we're going to know more in 2 weeks than we know today, and I think it will know a lot more in 2 years. That doesn't help you with that question, but what I think you can do is make sure that you follow the basic pillars of infection control, because those really do keep you safe. And sometimes if those break down and you get infected, talk to your docs, make sure you're on the right therapy, and if you start to get short of breath or need oxygen, you come into the hospital and let us try the things that we know are making a difference in how patients do. If we look at our data, I think our death rate is running around 8 to 10% here in our hospital. That's better than is reported in other countries and better than was reported in New York initially. But I think it's what we're all seeing in the United States, which is that if you use the right therapies and the right interventions, whether it be convalescent plasma, Decadron, anticoagulation, etc., all those things can make a difference with how people do. So there are therapies. Those therapies we believe help improve the outcome. The more significant your underlying diseases are, the more at risk for a bad outcome with COVID you have. And where that exact curve takes off above the baseline, I'm not really sure we know that yet.
Tara is asking, in the beginning, we talked a lot about patients suffering cytokine storm.
Cytokine storm.
Is it still around? Does it still happen?
Oh, cytokine storm still happening. We don't talk about it as much, but it's clearly still happening. And we know that unleashing of those things that the body sends in, because the first line of defense, when your cells come in to fight an infection, one of the first things they do is release cytokines, and that's to try and kill the virus. And in some cases, for some reason, what should happen is that antibodies arrive, and then the cytokines begin to subside. But in some patients, for reasons we don't know, and by the way, it's not unique to COVID-19. It can happen in a lot of infections. The cytokines arrive, then the antibodies arrive, but the cytokines don't turn off. They keep going. And then sometimes they even escalate that. It's like short-circuited cytokines, which I think, Dana, is bad news.
Yeah, absolutely. And I think the key, the other key word or key phrase to understand here is immune dysregulation. And just as you said,
that's a big word or big phrase.
That is. There's a lot of syllables. So it is 2 words. You can break it up, but immune dysregulation.
What does it mean, though?
So basically, we understand, and just as you said, we know that other infections, especially viral infections, have ways to evade or hide from the immune system, because once you come into contact with something foreign, like a bacteria, like a virus, our immune system is already kicking into gear. What these viruses can do is they can have genes that allow them to evade or hide from the immune system. And one of the major things is actually a downregulation or evading of interferon, which is one of the first cytokines that's produced. As you get further into the disease process, then that is one of the immune molecules that does start to react. And after you have that then, so you already have from the initial stages of infection an immune dysregulation. Your immune system is not working correctly. And then as it is allowed to catch up, then you have a delicate balance in any infection between how much inflammatory process do I give and when can I pull it back. And what we have later in the courses of COVID, especially for the critically ill, that balance is really tipped in one direction or another, leading to all that inflammatory process that leads to those lung infiltrates and or the blood clots that we see. So we are working, and some of these drugs that we are looking at repurposing are targeted towards decreasing that immune dysregulation as well. And some of those are the cytokines, which we refer to as the cytokine storm, trying to produce those molecules in the correct amounts at the correct time, rather than in abundant amounts at the wrong time.
All right, Kim wants to know if you can answer this question and reconcile for her. She may want to stay and watch the video at the end of this broadcast, but she's saying, is it 6 feet, 8 feet, 10 feet, which is what you recommend? She goes, Johnson County says you just need to stand 3 feet. So she wants to know what is it? What's the number?
Well, I think a lot of it will be answered to some degree. It's not a perfect degree, but we do have another one of those cool freezer videos where Dana and I go to try and explain some of what happens when you create a breath cloud. And you'll see that at the end of this broadcast. The further away, the better. The World Health Organization says 3 feet. The CDC says 6 feet. And others say 10 to 12 feet. But a lot of it depends on what you're doing. And the reason it depends on it is this. When we breathe, we create a cloud around us. The cloud is from the stuff we've exhaled. The virus, as we exhale, sits in that cloud. The further away you get, the less dense the cloud is and less virus is in it. So what we know is that is both the intensity of your exposure, that is how much virus you're being exposed to, and how long or the duration of that exposure that help define whether or not you're going to transmit that to someone else. So intensity and duration. the closer you are to me if I'm sick, the more likely you are to get into my breath cloud and to have a higher concentration of viral particles. That makes you more at risk. So the World Health Organization has said, look, we think beyond 3 feet, the risks begin to drop off. CDC says we think beyond 6 feet, the risks drop off. And both things are correct because both statements are true. Because really what it's saying is the further away you are, the better off you are. But it also depends on how hard I'm breathing. So if I take in a really deep breath and blow it out really hard, my breath's going to go 6, 8, 10 feet. Which is why they say if you're around somebody who's exercising, be further away, be 10 or 12 feet away. But if you're by somebody who's just breathing normally, it may be 3 feet. So a lot of it depends on the dynamics. It also depends on where you are, if you're inside or outside, whether the breezes are out there to help disperse those viral particles, or if they're just going to sit and hover in that breath cloud.
Yeah, and I would agree. You know, I think the World Health Organization would endorse that too, except they do have to reach an audience around the world where sometimes in some places you can't separate by 6 feet. So that's the audience that they're reaching. The same can be true for some instances, as we've talked about, especially in multi-generational housing, where there's a lot of people living in one space where it's hard to get to that 6 feet. But certainly the main point is the further away, the better.
Patrick, I'm going to bet that down at Wyandotte County and at Vibrant, y'all have tried to take special precautions to keep people safe by distancing.
Are you asking, have we?
Yes.
Yeah, so we have from a staff perspective, we have a number of our team working from home. We are temperature screening everyone that comes into our clinic, making sure everyone has a mask on. We've moved desks around for our clinic support staff so that everybody's got the appropriate distance, and created desk spaces where they weren't before, to try to make sure everybody's safe. So everybody that comes into our clinic has a mask on, is temperature screened. Our staff are temperature screened every day, and we talk a lot about symptoms and social distancing. And it's not perfect, but we definitely have the procedures in place.
Yeah, and then those procedures keep us safe. And you'll see the impact of that, as well as whether or not you need a mask or you don't need a mask, or whether or not a face shield works. So take a look at the video at the end.
We're going to have a pediatrician on again very soon, but Jennifer is asking if you can weigh in on 3- and 4-year-olds wearing masks in a preschool situation. She has heard that it causes emotional damage and developmental delays. Any thoughts?
Okay, I'm just going to say that I'm not the 3- and 4-year-old expert, and I'm going to probably dodge that question long enough for the pediatricians to come back and let them help us answer about the developmental delay questions. The more you can wear a mask if it's safe, that's great.
Yeah.
It's tough. My kids are 3 and 4. Wearing a mask would have been a challenge, Dana.
I would agree with you. You know, we don't treat children. I was talking to one of our pediatric colleagues yesterday, though, so it is a sample of one. And that person said that they are putting their mask on their young child as well. So I think we'll wait for the pediatrician overall. We do understand it's more difficult, certainly in children under 2, for many reasons. But I think we'll kind of wait.
Yeah, Patrick, you have a young child. How's that mask wearing going?
Yeah.
I do. And our chief medical officer is a pediatrician, and I'm sure she'll appreciate me quoting her here. Our direction to patients has been under 2 don't need a mask, but over 2 try. So
and how does it work for you at home? How's your daughter?
She's 20 months. So
okay.
She did okay with it the couple times we had her out with a mask, but doesn't last terribly long.
Yeah.
But I will say, interesting. You know how kids absorb, especially that age, absorb all of the stuff that we're doing. She now will take, as we are all in masks all the time, she will take a mask off her older sisters and say, my mask. And so it does. They do adapt to it.
They do take cues from others in the household. It can be fun with games or superhero masks or puppy dog pals, whatever that child may like. I think there's ways to do that. But.
Okay. Well, I think we have more to answer on that, Jill.
Yeah.
Nancy is confused about testing, and she just wants to understand when people are told to get a test. Her story is 2 people positive, 1 negative in a family. Now an elderly person with symptoms, and they're telling, don't get grandma tested, don't need to.
So, I think testing is confusing because we've made it confusing. And so you have every right to be confused. And different health systems will probably give you a different answer, and different docs may give you a different answer. And that's because we don't have a national testing policy here in our country, and we don't really have even local testing policies. It's highly variable from one group to another. In the situation you described, I would say, go get grandma tested, Dana. Even though the presumption may be she has COVID-19, there's going to be a lot of anxiety in that setting. And in that setting, I think I would still want someone to be tested.
Yeah.
What do you think?
You know, I agree with you. It seems likely that it's probably the same process going on, the same infection. Getting tested, I agree. You know, will that help the social and emotional and mental aspect of that, getting tested? That is a reasonable thing to do for that way because you are symptomatic. We certainly don't want you to get tested if you're not symptomatic, but now if you have symptomatic disease, if you can find a test, it's probably reasonable. You know, you still want to be isolating for those 10 days, monitoring your symptoms, monitoring your progress. Do you think that you are getting worse? Do you need to seek medical care? But
yeah, I think that's key. And then if you come in the hospital, you don't have to wait on the result of the test. You know what's going on. You can go ahead and get started on some of the therapies that we do have available for COVID-19. And I think it helps address the question. The other thing just to say is there is a routine summer cold out there, and we've seen it because we've been doing we still do a lot of negative tests. You know, 90% of our tests are negative. And often those are in people who we thought were going to have COVID.
Yeah, absolutely.
The only thing I would add, is I think there needs to be more information, more sharing, and getting the message out that people should presume positive. And so, as an example, we're doing all these testing in community pop-up sites, and a couple of weeks ago, I was registering people as they come through to be tested and talking to them about their symptoms. And multiple cars came through where they had been around someone who had been tested before but didn't have their results. So between the time of their test and the time of their results, which is 3 or 4 or 5 days, they had been socializing. And so then they said, well, on Monday they found out that they were positive, but they were tested last Wednesday. Had they presumed positive when they were tested and behaved accordingly, as Dr. Hawkinson said, the carload of people that we were testing may not have had symptoms or may not have had concerns because they would have presumed positive. And I think often we've reached people to tell them their positive results while they're shopping at Walmart. People have sort of defaulted to, I'm not positive till they tell me I'm positive. And what we need people to do is presume if I'm getting tested because I have symptoms, I'm positive.
Yeah, what we tell people to do is that if you think you have to get tested, or if you get tested, you should be quarantining at home. And then if you're negative, go have a party. Actually, don't have a party. You can have a party of one. You can stay at home. You can stay socially distancing. You can still party. But the reality is you shouldn't be around a lot of other folks until you know you're negative. And I think that's the key. And for Grandma in that situation, the question that was described, you should be in that setting. I would presume Grandma's positive. I would want her to be tested to find out. And then I would still say, we have to treat her like she's positive. I think for an elderly person, that's really hard to be isolated. It's hard for any of us to be isolated. But if an elderly person who's maybe come shut in or something of that nature, that can be really difficult. So yet another reason to get tested and find out the answer.
I think we would all advocate for more access to testing with accuracy and, of course, efficient, timely results.
And Dana, just to follow up on that, with salival testing, which may not be as accurate, are we going to see more widespread testing? Still very accurate, just not quite as good as the nasal swab. What are your thoughts about the role of salival testing?
You know, I hope we can. I hope if there are labs out there who can do that, who are able to have high throughput of many tests so that they can get the results back before 3, 5, 7 days. Certainly we know of a company here in Kansas City area that's doing it, and as we can get more, I think it's one more thing that we can use along with the NP swab, the nasopharyngeal, which is the gold standard, to try and get access of those tests to people who are out there in the community who are having symptoms.
We are going to have people from CR.
Okay.
CRL.
CRL
Reference
labs.
Yeah.
They are going to be coming on soon. I haven't talked to you in a few days, but we have lots of updates. So you sort of answered Carol's question, or you've alluded to it. Her question was when Dr. Leesman was on, who's from our laboratory, and she was talking about doing a analysis comparing the validity and reliability of saliva versus the nasal pharyngeal test, and she just wanted to know, is that jury still out? Do we
I don't
have
know that. So Dr. Leesman is brilliant, that does a great job for our lab, and she preaches this all the time. You do the best thing that you can, and a nasal swab is the best standard. I don't think there's any question about it. A different question has to be asked from a public health perspective. If you're trying to do mass testing or screening, do you have enough swabs? Well, saliva is easy to come by. Swabs, not so much. Can you get enough people done, and can they do it on themselves? Because one of the questions is also, can you even do these tests at home? A nasal swab's hard to do to yourself. It's hard to have somebody else to do for you. But doing a spit test is probably a little easier. Now, I don't think that's good enough if you're going to come into the hospital and have to try and get on therapy. That is a different question. But if you're trying to do mass screening of a large population, like we're trying to do with reopening a college campus, we're using salival testing. And the reason is we can't get 35,000 swabs done in a short time period. We can get 35,000 saliva samples done, and we can run those. So there's a lot of science. You'll hear more about it when CRL comes on. The other thing you can do with saliva is you can pool 4 or 5 people together, because the process detects a small number of viral particles. If that sample of 5 people is positive, you go back and you test the original portions, because you leave some sample behind, of each of those 5 contributors to it, and figure out which one of those are positive, and then you notify the patient. But doing 5 at once, and usually those are all that big batch of 5 may be negative, then you can go on to the next 5, and so it helps you have a faster throughput of the test. But again, that's mass screening of a large population and not answering a very specific question: do you have COVID-19? That's a nasal swab, I think, Daniel, at least today.
Yeah, absolutely. And Dr. Leisman was talking about validating it here internally, not validating other companies. So if we do choose to use a company for the saliva test, she just wants to make sure that it's validated against our gold standard here, what we already know as far as our test positivity rate, making sure that everything lines up so we're still accurate.
Yeah, you want to make sure that those people who have COVID and are detected on a nasal swab are also detected by saliva. And what we know is that 96-97% of the time that is true.
Yes.
It does miss some, not a large percentage. And again, for mass screening, that works. I don't know that for individual cases where you're suspicious and you're going to start drug therapy, I'm not sure that that's the right thing. I think that nasal swab is the standard.
Well, and we'll follow up with Dr. Leisman, too, to see where we are here at the health system.
We'll bring her down.
So Janet has a question. She says, based on your recent travels, she's kind of curious about what you saw, what you found, how you felt about it, and do you think that hotels or rental places are better?
Yeah, that's a great question. So, what you've heard us say before is that the principles of infection control follow you wherever you go. And so I don't know that travel is inherently dangerous if you're trying to follow the principles of infection control. Because if I don't follow them and I go to Walmart here in Kansas City, I'm exposed. If I go to the grocery store or the hardware store, I'm exposed. Conversely, if I wear a mask and I travel in my own car and with my family who's inside my bubble, and we stop to get gas, but we all have masks on and we do a good hand washing, I don't know that we're any more exposed. What I can tell you is different states are treating it differently. I was in Iowa. Some people not wearing masks in Iowa. I went to Wisconsin. Wisconsin's had an uptick. People were better about wearing masks there. And so part of it is a cultural question about where you're going. The other thing is, when we look at maps, we don't just look at states, we look at counties. And when I look at a county, I try to find a county with a low infection rate and a beautiful outdoors. And those two things can go together, because if you go try and hide out in the forest, trees do not transmit COVID, at least not easily, I don't think. Right. And so as a result, we try to find an area where there's a very low prevalence inside a county. We stay in a place where we think we can be safe. So I do think a home is probably better than a large hotel. But it really matters what you do when you're there. Do we go out to a lot of restaurants and big and crowded bars? Nope. Do we go out and stand around a forest or get in a canoe and take a trip down a river or take a hike and things like that? Yep. I feel pretty safe at that. And I don't think it matters so much if that forest is in Kansas, Missouri, Wisconsin, or wherever. I think what matters is how you act and how you conduct yourself while you're there.
All right. Janet and Diana have questions that are different, but I think what they're getting at is the same, and it may go back to what you were talking about earlier, Patrick, about presumptive positive. it's Jane, sorry. Jane is saying, how do I know the difference now that I'm going into cold and flu season? And how should I behave? And Diane is asking, I've been exposed to somebody, but work is telling me, go ahead and come on in, just make sure you wear a mask.
Okay,
And
so
so
let's
they're wanting
unpack
to-
those questions,
That's a lot
because there's a lot of
lot of
both of those
information.
questions that'll probably kind of help push us toward the end of the program today. So what are you telling your employees, Patrick?
Oh man.
Yeah, I know, that's what we say.
Today's
Oh,
Thursday?
boy, here we go. That's right. It changes every day. Let's see. It's 8:40. Yeah, we're going to change in just a minute.
Right. So if there's direct exposure, we are testing, and we have recently have acquired some rapid testing kits. So we're using those for staff rapid testing to confirm positive or negative, asking people to quarantine until we also send in the nasal swab. And which may take a couple days. So to get test results. So if people have direct exposure, we are testing them and asking them to wait for results. If it's and same with symptomatic. If people come in with symptoms, and we're sort of rating it on, there's 4 or 5 symptoms. Some are more seem to be more like fever seems to be tied a little bit more closely. We're rating what's the number of symptoms they have and which are they, to decide do they work with a mask or do they go home and get tested.
Yeah, it's a hard question, and Dana, we've actually changed a little bit here, but we've changed in being consistent with CDC and World Health Organization, that an employee who's exposed can still work as long as they have masks, et cetera, because we don't know that you're going to be positive, and we know that masks protect you and protect others around you. So talk a little bit about our stance around that.
Yeah, so first of all, we have all of our caregivers wearing masks and eye protection. So that will reduce overall their exposure. We also really encourage our patients to be wearing masks. So if either our healthcare worker or our patients have the disease and don't know it yet, if they are wearing that mask, that's going to provide that barrier. If both people are wearing it, that's going to reduce your risk a lot as well. And if we can continue to maintain that distance from each other until you have to do an exam or give medications or do a procedure or something like that, that is overall going to reduce your risk. So because of that, we have kind of gone in line and allowed people to work because we feel that those exposures are low risk exposures. So working while monitoring for symptoms, but that is all in the face of wearing appropriate PPE to overall have reduced that risk of exposure and infection.
Yeah, it makes a big difference. And the cold and flu season is going to be up on us before we know it. What we've got to hope is, A, it's a mild flu year, B, everybody gets that flu shot because that clearly protects us, and C, the things we do every day to protect us from coronavirus will help protect us from influenza as well.
Yep.
And so we won't know how that goes. That scares us a lot. But unfortunately, we can't change the fact we're heading into it. We can only change our behaviors around it. And those are, again, the principles of infection control.
Yeah.
So as we wrap up today, final thoughts?
Yeah, we are getting ready for flu season. We're either coming out of flu season or going into flu season. Not only influenza vaccine, but remember other common vaccines, tetanus, shingles vaccine if you're over 50, and then most importantly, childhood vaccines as well, because a lot of during this COVID, we have seen that people have not been seeking routine medical care. So talking with your caregivers or getting in touch with your clinic to get those routine vaccines, including influenza, when it comes out, when it's available.
Patrick, final thoughts today.
Well, I again appreciate you all having us and having me to talk about what we're doing at Vibrant Health. KU has been a significant partner with our efforts at Vibrant Health to help the community. We've had clinical staff at our testing sites for over the course of a couple of months. We send all of our tests from those community pop-up sites to the lab here. So have a great working relationship with the people you all have mentioned in the lab, and appreciate what the health system has done to support Vibrant Health and Wyandotte County particularly. We are, like many nonprofit, we're a 501c3, like many nonprofit organizations, we rely on philanthropy. And we had an event scheduled for the fall, our annual, it's not quite a gala, but our annual gala that we've had to move online, and we are doing in a campaign format instead of an event format. So we've created a vital need for Vibrant Health. The health system is a big sponsor of that. Brenda Dykstra from the health system is a co-chair, along with Kathy and Terry Matlack. And so any consideration from the public to support our efforts, we're looking at about $1.5 million loss in patient revenue for important care and important work in Wyandotte County. So any consideration from the public would be great and appreciated.
And Vibrant, thank you. And Patrick, thanks for all the great work that you've done and all the great things that Vibrant does. And Vibrant is a great partner and has a great heart. And it doesn't get any better than that. So as we wrap up today, a couple of housekeeping things. First of all, we're here tomorrow to answer your questions as we do head into fall, and we know there are going to be more about that. So Dana and I are taking it on, and we know there'll be a good number of questions. We'll do our best to try to answer those and tell you what we know and give it to you honestly. A couple of other things as we sign off today. Thank you to Connie, who sent this photo of her grandson. Be true to you. I love that. Wearing a mask while shoe shopping. There's nothing better than buying shoes for kids. I used to love to do that. And Ed sent this in with the kids sporting their leopard masks and mom in her bright pink at the zoo. Kids seem to do pretty well with wearing masks, man. We do love seeing that. So please keep sending us the pictures of how you're doing wearing a mask, because masking is really important. In fact, it's the key together with social distancing. And gosh darn it, we have a cool freezer video 2.0 to show you. It doesn't include singing this time. That comes back in the third act. Remember, there is a 3-act play in the freezer. We still have one more to do. There will probably be a few song tunes in there, maybe some dancing from Dana and I. Hopefully not. You don't want to spoil your day. But most importantly, this one's a little more serious, and it's really designed to show you what a breath cloud looks like and how masks do protect you. Take a look. We'll see you tomorrow.
We're back in the freezer. I'm here with good old friend Doc Hawk.
Hi.
How are you?
It's cold.
It is cold. This is our cool tape measure. What does it show us? 6 feet. Let's see how far our breath goes. That was a big breath. It's going 6 feet.
Getting here.
Now on normal breath, we were just talking, probably about 3 feet. There's the tape measure just to be showing you how far it goes. Now we're going to put a mask on. Let's see what happens. Can we keep each other safer? Let's take our deep breath. Man, I just saw a little breath go out a couple of inches. How about you?
Yep, not too far at all.
All right, a couple of easy breaths.
Even just talking, nothing.
Nothing's going on. Once again, masks keep you safe. But let's see what happens when we put on a cloth mask. Shall we take a deep breath and try it again? I don't know about you, but my glass is totally fogged up.
I just get fogged.
I don't see the breath either. Pretty awesome. Let's see what happens when we try it with a face shield. Face shield on. Where does my breath go? Uh-oh, I'm seeing a little more coming out. Dana, how about you?
I think it's coming out below.
That's the problem with the face shield. It just goes down, still gets into the air. And when you stand here and you breathe, pretty soon, I create a little breath cloud all around me. And then other people walk through my breath cloud. That's why masking is so important, because Doc Hawk, he doesn't create the breath cloud with the Chiefs mask on.
Nothing.
It's awesome. So you know how to stay safe? Do the thing we've been doing in the operating room for generations. It helps keep you safe there. It helps keep you safe on the streets and in your home and everywhere you go. Wash your hands. Keep your distance. 6 feet, there it is. Make sure you wear a mask. Keep yourself safe. Keep your family safe. Keep all of us safe. We can do it together.